doing attentional and motivational interventions for excessive alcohol consumption. Whether it's attention or motivation, though, both of these focus on motivation, because the reason why we focus on motivation is because drinking alcohol is goal-directed behavior. The person is trying to get something by drinking alcohol, either to get, obtain, or accomplish something positive that they want that is going to make them feel better, or something negative that they want to get rid of, prevent, or avoid. The alcohol they perceive is going to help them to achieve that. With regard to motivation, the construct with which we work is called current concern. It is the motivational state of the individual between 2 points in time, the one of becoming committed to pursuing a particular goal and the other of either attaining a goal or giving up the pursuit. The reason why this is important is because during the time that the person has a current concern, the current concern helps to guide their mental activity. It helps to determine what they think about as they go about their daily activities, what they pay attention to, selectively attend to in the environment, what they recall, and even what they dream about at night. So with regard to alcohol, there are stimuli everywhere in the environment that might capture a person's attention who has a concern about drinking alcohol. They selectively attend to these stimuli, they enhance their motivation for drinking and their actual drinking behavior. And they might even distort the person's cognitive processes, as shown by this gentleman who has the rule of having just 1 glass of alcohol per day, but you see how his perceptions are distorted. So to reiterate, the point that I'm making is attentional bias for alcohol is that people who have a goal of drinking alcohol selectively attend to alcohol-related stimuli, and the attentional bias affects the actual drinking behavior. There's a way in which we measure attentional bias. It's not just an interesting epiphenomenon, but the behavioral technique by which we measure it is called the alcohol Stroop test. It's generally a computerized test. It involves 2 categories of stimuli. They're either alcohol-related, words like wine, beer, tavern, spirits, whiskey, or emotionally neutral words. These words are presented in different colors, red, yellow, blue, and green, and the participant's task is just to say the name of the color in which the word is presented. But if a person has a concern about drinking alcohol and they're asked to color name these words, they're vastly slowed down in the ability to name the colors because they can't help to attend to the meaning of the stimuli if it's alcohol related. So extensive research has been conducted with the alcohol Stroop test, and some important conclusions from this research are that the degree of alcohol interference from the alcohol-related words is generally proportional to the amount of alcohol that the person habitually consumes. That is, alcohol abusers have greater attentional bias than non-abusers, and heavy drinkers have greater attentional bias than light drinkers. Alcohol attentional bias is accompanied by actual physiological reactions, such as increased skin conductance and heart rate deceleration. Greater attentional bias predicts a greater likelihood of alcohol abusers relapsing after treatment. So then, alcohol attentional bias has important clinical implications. Interventions are needed to help abusers gain more control over the automatic, unconscious triggers of their behavior. So then we have developed an intervention that does just that, called the Alcohol Attention Control Training Program for reducing alcohol consumption by overcoming attentional bias. The goal of the program is to reduce the time that alcohol abusers need to divert their attention away from alcohol-related stimuli and helped them gain control over the automatic nature of their selective attention for alcohol stimuli. The structure of the program is like this. The participant responds to several kinds of stimuli. One is individual stimuli with a broad background color that's supposed to respond only to the color, or for more difficult stimuli, the color is only a narrow band surrounding the alcoholic or non-alcoholic bottle. Or the third category is paired stimuli that includes one alcohol stimuli and one non-alcohol stimuli. The person is supposed to ignore the alcohol stimuli, pick out the color of the non-alcohol stimuli. The goal of the training is progressive reduction in response times and number of errors while the person is trying to ignore the alcohol-related stimuli. And it provides goal setting and immediate feedback. So this is the way the program begins. You see two flags here because there's a British version of the computerized program and a Dutch version. So in the beginning, they're just preliminary things that you set up, such as the person may practice in the beginning before the actual training begins. You choose which kind of stimulus you're going to use that I've just been describing. The broad rectangles, the halos, or the pairs of stimuli, and so on. You set up things like the number of trials that you want to include in the task, the width of the band surrounding the stimuli, the number of stimuli in the task, and so on. In the beginning, there's a baseline test to determine the person's degree of attentional bias. So here's an example of an alcohol word where the task is simply to say green. But remember, if it's a person who has a concern about drinking alcohol, they'll be slower than a person who does not have such a concern. And then reaction time to that kind of stimulus is compared to this one, which is neutral in emotional valence. Another neutral stimulus. In the beginning, the person chooses their favorite alcohol beverages and their favorite non-alcoholic beverages that are going to be used in the training task. There's a bank of several hundred different stimuli like this. We were fortunate in being able to choose the stimuli because we had a research assistant working with us who happened to work at Tesco on the weekends. So through her, we were allowed to go to Tesco, choose alcoholic bottles from the shelves, take them into the back room, and make these photographs. So this person here, you see, they like to drink Bacardi, two various forms of that. Then for their non-alcoholic beverages, they like Coca-Cola, the ones shown in red, or the ones that this person chose. Okay, so here's an example of the easiest kind of stimuli. With a non-alcoholic bottle, the person just says green. You compare that, though, to this more difficult one, an alcoholic bottle with a narrow band of green. In both cases, the person's task is just to say green. For the paired stimuli, the person is supposed to ignore the alcohol bottle and choose green for the non-alcoholic bottle. So when you've gone through a series of training trials like this, at the end, you provide feedback, try to make the person feel good about their performance. Well done. You've made fewer mistakes than the allowed limit and so on like that. And the numbers to show how their performance compares with their baseline performance. And this continues over a series of trials. In the first study to evaluate the effects of the AACTP training program, the participants were very heavy drinkers. The mean alcohol consumption was 71.52 units per week. The procedure design of the study was like this. First, there was a baseline assessment to measure attentional bias. Then there was a 4-week waiting period in which they did nothing at all. Then 4 weeks of training with a computerized task. Then a post-training assessment of their attentional bias and alcohol consumption, and a 3-month follow-up assessment. The results look like this, where there was significant reductions in the attentional bias of alcohol stimuli. The most relevant line here is the pink one, showing performance on the alcohol Stroop test. You see there are significant declines from baseline to post-test to follow-up. More importantly, though, notice that on this graph that there were large reductions in the person's actual alcohol consumption, their normal consumption as they went about their daily activities from baseline to post-test, and the reduction was maintained at the 3-month follow-up. There were also other improvements, such as increase in the person's readiness to change their alcohol consumption, an increase in their positive affect, the way they felt, an increase in their situational confidence. That means their confidence in their ability to resist drinking in particular high-risk situations, and a decrease in alcohol-related problems. But though, if excessive drinkers, or even if they are able to overcome their attentional bias for alcohol stimuli, is that all there is to it? Or should more be involved in the treatment of excessive drinking? Well, I think there's more to it, and this is illustrated on this abbreviated version of the motivational model of alcohol. What it attempts to do is to bring together all the variables that feed into a person's motivation to drink or motivation not to drink. It goes through a pathway with a final decision ending here with a decision to either to drink or not to drink a particular drink of alcohol on any particular occasion. So the variables include things like biological factors, the person's own biochemical reactivity to alcohol, the degree to which it's positive or negative, environmental factors, cultural factors. The box that we focus on, though, is the other positive and negative incentives in the person's life that might compete with their motivation to drink alcohol and the corresponding positive and negative affect that they experience. And there are important reasons for believing that the other incentives that are available to the person to pursue and enjoy are an important determinant of their ability to reduce their alcohol consumption. Some of the reasons are shown here. We know that there are high rates of relapse among people who've gone through traditional treatment programs. In fact, within 3 months after apparently successful treatment, 60 to 70% of patients have relapsed. However, if we compare patients who have relapsed with those who have not relapsed, we note important differences. The non-relapsers report that they've had more positive changes and fewer negative changes in other areas of their life than those who return to drinking. When asked how they were able to change their drinking, non-relapsers report that they developed substitute activities to take the place of drinking. A person is not just drinking abusively or not drinking, but there are fluctuations in drinking across time, and these fluctuations are correlated with the degree of emotional satisfaction that the person is experiencing at any particular moment in time. There are various kinds of treatment that a person can go into, such as disease model, cognitive behavior therapy, and so on. But what matters more than the type of treatment that the person has received is what happens in the person's life, the kind of environment that they go back to after they return to their normal environment. That determines more whether they're going to drink again or remain abstinent. So then what we want to study then is what's happening in other areas of the person's life, in particular their motivational structure, the person's goals and their way of relating to them. What is it they're trying to achieve in their life that's going to make them happier? How are they going about achieving these things? Are the things realistic? Are they really going to make their lives happier if they actually achieve them, and so on? So we measure motivational structure with this questionnaire or assessment technique called the Personal Aspirations and Concerns Inventory. The general instructions explain that undoubtedly you have desires and concerns about different areas of your life. You might have desires about pleasant things that you want to get, obtain, or accomplish, or you might have concerns about unpleasant things that you want to get rid of, prevent, or avoid. In other words, these are things that you want to make happen. Let's call these things goals. Then the assessment is broken up into these different life areas: home and household matters, relationships, finances, health and medical matters, and so on, so as to jog the person's memory so they won't forget any important concerns that they have. Then in their own words, we have them in each life area name the concerns that they have and their corresponding goals. In some particular life areas, a person may have one concern, in others I may have multiple concerns, in others I may have none at all. After they have named in their own words their goals, then we ask them to rate them along different dimensions, such as how much is this something you want to get, obtain, or accomplish, as opposed to get rid of or prevent or avoid. So this person answered a 10 to that first rating scale. It goes on, how committed am I? How much effort are you willing to put forth to make this thing happen? How happy will I be if I actually achieve it? And it goes on like that, asking these questions about the goals. Then when the person rates all of their goals in this manner, we draw a motivational profile for each person to pinpoint any maladaptive motivational patterns that the person might be having that we might be able to correct. So here's an example of one motivational profile, a different one, yet another one. So this here is an example of an adaptive motivational profile. What I mean is the person rates very highly on appetitive things that they want to get, obtain, or accomplish. It's more psychologically satisfying if we have good things that we're trying to achieve rather than bad things we're trying to get rid of. The person feels committed to these things. They're willing to really put forth the effort to try to achieve them. They imagine that they will receive a high degree of happiness if they actually achieve the things. They know what to do. They feel a sense of control and so on. Contrast this with a maladaptive pattern where the person mostly has things that they want to get rid of, prevent, or avoid. They don't feel terribly committed to the things. Wouldn't be. They do imagine being happy if they were able to achieve them, yet they don't perceive much sense of control and so on. So then, after we have identified individually each person's motivational profile like this, we have interventions for trying to help to change maladaptive patterns into adaptive patterns. One technique is an extended 12-session individual counseling program called systematic motivational counseling. Another one, a brief workshop version of it, consisting of 4 modules, where it's done in a group setting, is called Life Enhancement and Advancement Program, or LEAP. Here are the 4 different modules that it consists of. Talking in the first session about why people drink in the first place, examining goals and concerns that the person has written down at baseline, preparing them to take action and putting it all together. Or here's a more extended description of the 4 LEAP sessions, but I'm not going to talk about this because this afternoon in one of the workshops, Dr. Hosier is going to the topic of his workshop is the leap, and he has first-hand experience in conducting it, so I'll wait for him to describe it. But anyway, finally, a research program in which we have evaluated AACTP LEAP. One group received only AACTP, the Attentional Retraining Program. Another group received LEAP only. A third group received both of the interventions, and the control group received neither of them. The results look like this in terms of, for the four groups, in terms of changes in their mean weekly drinking across time. For the control group, in which both conditions were absent, there were no changes across time from baseline to post-treatment to the 6-month follow-up. For the group that received LEAP only, there were progressive reductions in mean weekly drinking. For the group that received AACT, though, there were initial reductions, but then that eroded by the time of the 6-month follow-up. So then our conclusions were, it appears that AACTP is sufficient to instigate rapid changes in the cognitive processes that are most proximal to decisions to drink, but is relatively ineffective at consolidating these changes so that they have a lasting effect. By contrast, the entrenched motivational patterns related to one's everyday life routine that the LEAP targets are difficult to change, but once in place, the changes are relatively long-lasting. In short, these results suggest that the AACTP would be more effective at bringing about short-term reductions in moderate drinking, whereas the effects of LEAP would be more enduring. There were no beneficial effects of combining the two interventions, so it appears that excessive drinkers must first learn to disattend to alcohol before starting to address their issues that motivate them to drink. So then, with all this as the backdrop, then we try to investigate people's brain reactions to alcohol and other concern-related stimuli to further help to explicate their motivations for drinking. Do I have time for this also? Or?
Yeah, 2 minutes.
Okay, so the question that we were answering was, the topic was incentive value of alcohol relative to other incentives. Do drinkers' brain reactions to alcohol stimuli help to account for their motivations to drink? So we had two groups of drinkers, light drinkers and heavy drinkers, and we were hypothesizing that the heavy drinkers who had stronger brain reactions to alcohol-related stimuli and weaker reactions to other goal and emotional concern and stimuli. So participants, both types of drinkers, were tested in an MRI scanner, like the one shown in the picture here. And we had, when they were in the scanner, they viewed stimuli related to alcohol, such as these, and that was compared with their brain reactions to neutral stimuli, like this. And we found that the heavy drinkers had stronger activation in the left and right insula and the nucleus accumbens to alcohol-related pictures than the light drinkers. By contrast, and the insula is implicated in drug craving. The accumbens is associated with reward, being part of the reward pathway in the brain. Mean weekly drinking was positively correlated with insula activation in response to the alcohol stimuli. When we compared reactions to other concern-related stimuli, such as those related to finances, relationships, education, compare those to the neutral stimuli, we found that heavy drinkers had lower activation than the light drinkers, just as we had hypothesized. So then, as the next step of this, we're now trying to train participants, train dependent drinkers, to overcome their reactions to alcohol stimuli and to upregulate their reactions to other important goal-related stimuli. And this is being done in an EU grant, in which we train over a series of sessions people to upregulate or to downregulate their reactions. When they're in the scanner, they see the particular stimuli, they're told to do whatever you can, whatever thoughts you might have, just remain passive, but have whatever thoughts you can to help control the activation to the stimuli. They see something like a thermometer that shows the degree of activation. They're told to try to bring it down, or the picture might get larger and larger as the activation increases. They're told to try to make it get smaller and smaller just by having whatever thoughts that you can, and to do the opposite for the concern-related stimuli. In addition to measuring their brain reactions and how they differ with the training, we measure the changes in their urges to drink, their drinking temptation and restraint scores, and their actual alcohol consumption. So the topic is real-time fMRI neurofeedback as a treatment tool for alcohol dependence, and it's being conducted, as I said, through an EU grant that involves these five different universities. So with that, thank you for your attention.